right. Dr. Alissa Greenbaum is an assistant professor of surgery at the UNM School of Medicine, specializing in gastrointestinal and peritoneal surface malignancies. She currently serves as associate program director for the general surgery residency at the University of New Mexico Health Sciences Center, focusing on resident wellness and surgical ergonomics initiatives. Her research focuses on Native American health, cancer screening, and intercultural approaches to healthcare, as well as large database research examining surgical outcomes in patients with gastrointestinal and peritoneal malignancies. She is the program director of the UNM Peritoneal Surface Malignancy Program, the only cytoreductive surgery and hyperthermic intraperitoneal chemotherapy, also known as HIPEC, program in the state. She is proud to serve the diverse patient population of New Mexico and surrounding areas of East Texas and Western Arizona. And then also joining us today is Dr. Kimberly Kopecky. She joined the UAB Division of Surgical Oncology in February of 2024. She obtained her medical degree from Harvard Medical School and completed her residency in general surgery at Stanford Hospital. Dr. Kopecky went on to complete 2 fellowships studying hospice and palliative medicine at UW Health University Hospital and surgical oncology at Johns Hopkins Hospital. She also earned a Master's of Medical Science in Clinical Investigation from the University of Wisconsin-Madison, and a special shout out that she received the 2025 $25,000 Young Investigator Award funded by us, the Appendix Cancer PNP Research Foundation, and administered by the Society of Surgical Oncology for her research proposal titled Aligning Preoperative Expectations with Postoperative Recovery for Patients Considering CRS HIPEC, a mixed methods intervention development study. All right, and with that, I'm going to turn it over to you guys. I think Dr. Greenbaum, you're going first.
Thank you very much. Make sure, can you see my slides,
Perfect.
Alissa?
Yes.
Great. Thank you very much for the opportunity to join all of you this evening. I'm really excited to partner with ACPMP again, and also with Dr. Kopecky. We've been developing our collaboration in the area of appendix cancer over the last year, and really enjoyed putting this talk together for all of you. Really just so you know, we have no disclosures, and as we go forward, we'll highlight this again when we answer your questions, but this presentation really highlights our knowledge and our opinions and is not meant to give medical advice. But the exciting part about today is really this partnership that we developed with ACPMP and with all of you, both caregivers and with patients. We were able to conduct studies to understand more specifically about decision regret, which I'll define a little bit more later, and about caregiver burden, which this paper is currently under review for publication. Dr. Kopecky will then go into some of her area of expertise that I'm really excited about, which is about expectation setting before surgery, and also her upcoming projects with ACPMP. So then once we cover this, we will get to some of your questions. Thank you so much for sending those in, and we'll also try to get to any live questions that come in. So I would like to start with a general overview of appendix cancer. This is Appendix Cancer Awareness Month, and anyone on this call probably understands how complex this diagnosis is. And so I'm going to go through pretty briefly how I understand appendix cancer and explain it to my patients. Some of you may already know this. I find people are very educated about their diagnoses, but if it's new to you, hopefully this is helpful. So it is considered a rare cancer still. The incidence of patients that have peritoneal metastasis, so cancer that's spread to the abdominal cavity, is a pretty wide range. The appendix can rupture and result in this spread in up to half of patients. A recent paper that came out of Vanderbilt that was very interesting, I encourage all of you to read, did show that even though it's a rare cancer, the incidence has been increasing quite a bit in recent years. So the process of appendix cancer spreading to the abdominal cavity and becoming what we call pseudomyxoma peritoni for the most part is when something blocks the middle of the appendix, and the appendix can actually rupture or what we call perforate. And then when the mucin, which is this gelatinous material in the appendix, makes its way out into the abdominal cavity, it can cause the pseudomyxoma peritoni or PMP or mucinous ascites. So again, this can get very complicated, but in terms of making it as simple as possible, I think about non-invasive disease. So this means that the types of cells do not have really the ability to travel through the bloodstream. They can be a big problem where they are, but they tend to or never go to lymph nodes or, for example, the liver. Whereas invasive disease and these more high grade, we call them types, are adenocarcinoma, specifically signet ring and goblet cell. There were some questions about, we will get to that. And then a whole other diagnosis of tumors that can happen in the appendix or neuroendocrine tumors. I wanted to show some photos and actually a video from the operating room. I have found with my patients, there are usually two kinds of people, people that want to see their tumors and really understand very deeply what's going on with their body and with their disease. But I do want to say that if you are squeamish and do not want to see photos from the operating room, I encourage you to look away, and I will tell you when to come back. You can listen to me like a podcast. So a lot of times people have a hard time visualizing what mucin actually looks like. On a CT scan, it can just kind of look like fluid. But this is actually what it looks like in someone's abdomen. So this was a man who had an appendectomy 10 years ago. Turns out not all of the appendix was removed. He developed a tumor in the what we call the stump of the appendix that was left behind. And this is spillage of mucin going into the peritoneal cavity. Tumors can be quite large. This was a young woman who developed a mass on her ovary. And you can see for scale, this is my hand and this is the tumor. So we took honestly about 4 liters of mucin out of her abdomen. You can imagine why people, and maybe some of you would have so many symptoms from this. In terms of more solid disease, this is an example of someone's omentum, which is basically an apron of fat that hangs over the organs, starting at the stomach and transverse colon. This was probably about 2 or 3 pounds. It was just solid tumor that had completely replaced his omentum. This is a video that I hope will play. Um, this is what a peritonectomy looks like. So when we talk about removing the peritoneum, which is the lining of the abdomen, this is my chief resident performing this procedure. So we're actually taking the lining of the abdomen off of the muscle. When we talk about how long these surgeries can take, this is an example of how tedious, honestly, it can be to remove each tumor. You can see we're literally taking a pair of scissors and taking the tumors off of the surfaces of the intestine. This is after we've placed the catheters in the abdomen to deliver the HIPEC or the heated chemotherapy. And we temporarily close the abdomen and then we agitate the abdomen to distribute the chemo and the hot fluid to kill cancer cells that we can't see. So in terms of where this all came from, the rationale I wanted to go over briefly, a lot of you may know the name Paul Sugarbaker, who developed this in GI cancer in the late 80s, early 90s. But his rationale initially was that pseudomyxoma can be a treatable disease, and by treating it with these regional therapies, which cytoreductive surgery and HIPEC is one of them, that we can actually prolong survival. Previously, and when we compare to what we knew in the 80s about PMP, survival was quite short. It could be as short as 6 to 8 months, but we did find that with these treatments, we could prolong survival. In terms of where disease ends up in the abdominal cavity, some really common sites end up being what's listed here, the right diaphragm. And I'm sorry, for those of you who haven't come back, the graphic photos are finished. So you can come back. The right diaphragm is very common because that's where fluid is absorbed back into the circulation from the peritoneal cavity. Pelvis, tumors end up there by gravity. The right colon because the appendix ruptured in that area. So a lot of times the small intestine can be spared, but a lot of times it is involved with disease. So with high volume disease, really any organ can be affected by pseudomyxoma. So his treatment approach was to do what he called maximal surgery, which was to physically remove all of the tumors that we can see. And this may involve peritonectomies, which we showed is the stripping of the lining of the abdomen, and or the viscera, which are the abdominal organs. Obviously, there's a limit to what we can do. And again, we'll talk about that in our questions. But we do what's safe for the patient. And then we give this regional chemotherapy, otherwise known as HIPEC, and distribute that throughout the peritoneal cavity to kill cancer cells. In terms of lingo that you might hear surgeons use, maybe you haven't heard this, we talk about the peritoneal carcinomatosis index. It's basically a scoring system that we use to relay how much disease is in somebody's abdomen, how heavy is what we call the tumor burden. And you'll see this in a lot of studies that are written. The highest score you can have is a 39. In terms of how complete the surgery was, we also have a scoring system. And the cutoff for what we consider complete is when we can get the tumors down to less than 2.5 millimeters. Now, obviously, you can imagine getting it down to no tumors at all is preferable, but there is a lot of research showing that patients may still have benefit if we can get it down to 2.5 millimeters. So in terms of what we're going to be talking about in this webinar, in terms of the surgery, really is a wide range of possibility. And this is the hard part where we have to talk to the patient and their family ahead of time of what to expect. So it can be as little as removing the appendix, maybe that peritoneum on that side, remove the omentum, and then we do a HIPEC. Maybe do a right hemicolectomy depending on your disease type. However, when we get to really high tumor burdens or high PCI patients, we could be talking about a very long surgery with a lot of morbidity or possibility of complications if we're going for complete removal of the tumor. So really the decision for somebody to decide to undergo such a large operation with so many different possibilities is a big deal for patients with appendix cancer and pseudomyxoma peritoni. So I became interested in this concept of decision regret, which has actually been around for over 20 years. It was first described in 2003, and it's a pretty unique emotion that is distinct from others that we know that might be negative. Really, it comes from someone knowing that another outcome would have been better than the one that they chose. And then second, the feeling of blaming themselves for having made a poor choice. So you can imagine when we're talking about surgery, this could have a potentially huge impact depending on what happens. And so this had not been applied very widely to surgical patients. There was a couple papers that came out before this survey that I partnered with ACPMP to perform. So I really wanted to relay today how grateful we are in my community in HIPEC surgery, peritoneal surface, of being able to partner with our patients and with groups like ACPMP. It's just invaluable to hear from all of you. So I wanted to relay the study that was completed and published, thanks to all of you, so that we could understand more about how you feel about HIPEC. And so we asked about some basic information. Again, this was anonymous, so we don't know who the people were, but it had to be somebody who had the procedure more than 30 days ago. And we did ask questions about their surgery, whether they had complications, and whether they had to come back to the hospital after surgery, a number of outcome questions. We also asked them about their symptoms, how they were feeling now. And there are actually some really great surveys that already existed to measure these types of things. In terms of quality of life, PROMIS 29 is a really widely used metric, and it measures quality of life in these 6 arenas. Obviously, physical function is huge after surgery, but also mental and psychological effects of anxiety and depression, even sleep. So we were able to ask all of you about this. We also wanted to look at how something called financial toxicity played into the patient experience. And these are some examples of the questions that were asked. There was 12 questions total, but it has to do with the stress related to the financial impact specifically of cancer treatments. And in this case, the impact of HIPEC on financial stress. And so the way that I began to think about these issues is they don't occur in isolation, and they potentially all affect each other. So where does HIPEC come into play when patients are going through this experience. So I want to tell you the results from the study. And again, this is published, so you can also read the paper. But we did the study in September of 2023. We got 125 responses, which I will tell you for a rare cancer, this is a great number. And again, we really appreciate everyone's participation in this. So in terms of patients that had regret about having their HIPEC procedure, it actually was the minority of patients. Only 14.4% regretted their procedure. That means the majority of patients did not regret having their HIPEC. Um, Most patients had lamin, so the more low-grade histologies, and over half of you actually had to travel more than 50 miles to have your HIPEC surgery, which is a whole other topic about regionalization and having access. But I thought that was really important. So when we look at the actual decision regret scale, you can see that most patients strongly agreed that it was the right decision for them. However, you see that the answers are a little bit distributed a little bit differently about the question of the choice did me a lot of harm. So I thought what was interesting about this is it wasn't that patients weren't saying maybe they were harmed in the process, but at the end of the day, they believed that it was the right decision and they did not regret their decision to have HIPEC. In terms of quality of life, what was most interesting is that quality of life was related to regret. So the higher regret people had, the worse quality of life they had. Now, we don't know if that's causal, as in that's causing regret, but it absolutely could be. In terms of factors that were associated with regret, some of them I would say make absolute sense. So patients that had a major complication had more regret. If they were in the hospital for more than a month, and if they had lower income, so potentially having that, more financial toxicity, had more regret. So there's so many areas that we can go from here, but it's a great foundation for us to do future studies to understand the patient experience in HIPEC. So I will present the next study, but we also want to perform more interviews and interactions with patients. And again, Dr. Kopecky is going to go into her really exciting project that's coming up that's going to address a lot of these things. So I want to transition a little bit to talk about caregivers. This is something that I would say it's unfortunate that only recently has it become a very, very hot topic, getting a lot of attention, not only in the medical literature, but in the press, in the worldwide news, especially in the US. So this is an example of a headline which says that 70% of people that are caregiving, and to be clear, this is not select to appendix cancer or even to cancer, but family members that are caregivers, there's really potentially long-term effects and severe impacts not only to them and their family, but to the US economy. So this was a report that Dr. Kopecky came across, and I'm glad that she sent to me because I was putting together this project, and this is from 2024. This group from Columbia University reported that 45 million people in the US are unpaid caregivers. And this compares to, and this compared to $875 billion a year of labor that is being done for free. So when we think about that, that is the sixth largest state GDP, and you can see some of the other comparisons here. It's just an absolutely massive role that people are playing in the United States. And when we compare to, for example, some other big entities and corporations, you can see that family caregiving, the value is 45% larger than Amazon, for example. So in terms of caregiver burden in cancer, there is usually a sequence that people are finding, and again, very smart researchers are beginning to study this process of a patient's diagnosed with cancer, and then there's this kind of shock that comes with this. And I would say it's almost what do we do now? What do I do with work? Do I need to leave work? What exactly is my family member going to need from me that I need to plan for? So 90% of caregivers do experience work disruptions, which I think you can imagine between appointments and scans and surgeries, it's quite a bit. So they also found that this can increase a feeling of isolation, anxiety, and depression. And so what is the ripple effect as we go downstream? I just want to give a couple examples of the caregiver experience in other cancers. This is in head and neck cancer. This was published, that caregivers were found to have their full-time employment decreased by 40% after 4 months. So you can only imagine, and again, I'm sure many of you on this call already know the impact, not just on mental health, that this can have, but on financial stress. Another study showed 15 caregivers, and qualitative means, we're not handing out surveys, we're really performing interviews and hearing from the words of caregivers their experience. And they found that really caregivers identify with these three main concepts, which is really a strong sense of duty. They understand why they're doing this. Their caregiving is a priority for them, despite the hardship, and also self-sacrifice, that right now, the interest of the caregiver is not at the forefront. It's of their loved one who's the patient. Obviously, there are also barriers, which we've talked about, financial strain, transportation, especially in a state like New Mexico, and I'm sure Dr. Kopecky's transportation can be a really big deal if people are traveling from 4, 5, 6 hours away to come see us. There is one study that was published by Wake Forest. And this is the only study that has been done in caregiver experience prior to mine, which did show that after HIPEC, the quality of life of caregivers did decrease. And interestingly, sometimes it's affected even more than the patients. So even compared to patients, caregivers felt like they had less social support and more depressive symptoms. So again, what are the specific challenges when we talk about HIPEC and appendix cancer? Again, a lot of you may be familiar with this, but a lot of times there's a delay in diagnosis. It can be a very confusing, complicated problem to finally arrive at, the HIPEC surgeon's office. A lot of uncertainty. There's logistics to work out. The surgery itself, as we've highlighted, is a big surgery. It has a lot of different variables, the possibility of complications, having to be in the hospital. And then long-term effects. Many people do, and we'll talk about this also with your questions, but a lot of people do fine after HIPEC. They recover from their surgery and they're back to eating a regular diet after anywhere from 4 to 12 weeks. Some patients do have longer-term effects in terms of GI discomfort, their appetite, and even sleep. Deciding when to return to work for caregivers can be challenging. When is the right time? Family responsibilities, especially as we're seeing more and more young people with these diagnoses. They have young children. There's a lot of responsibility. And then, of course, going into survivorship, again, many of you know, it doesn't end when you have the surgery. You then go into surveillance. There's a possibility of the cancer coming back. There's a possibility of repeat surgeries. And again, all of the logistics that come along with managing your survivorship. So in terms of caregiver burden, I'm just going to check the time to make sure. Caregiver burden, much like decision regret, it's a very unique measurement that really pertains to the negative influence that a diagnosis of a patient has had on their caregiver and their physical and psychological health. So I was very interested in, again, in a big surgery like HIPEC, what does this mean for our caregivers, specifically those in appendix cancer? So there is this, again, this metric, which is 12 questions. And we did ask, again, all of you this. So these are examples of questions asking about stress, asking how you feel. Do you feel like you could do a better job? Is there self-blame or guilt themes coming up? So again, to briefly summarize, and this is unpublished data, hopefully it will be published soon for all of you to review your responses. So we had 34 caregivers. The average age was 49 years old. Most were female. And half of caregivers did report that they had high burden scores. So specifically, stress, those responsibilities that we mentioned between caring for their family member and all of their other responsibilities was the main burden. And so we also, again, tried to tie together how decision regret, quality of life, and again, that financial stress or financial toxicity tied into this experience. And so we did find that the higher the caregiver burden, the worse quality of life. And again, we don't know which one is causing which, but also with decision regret, that there was a higher decision regret in caregivers when the patient had an incomplete side reduction. So that means not all the cancer could be removed, or that they had a higher grade histology. So for example, signet ring or goblet cell adenocarcinoma. So I'm just showing the distribution of questions. You can see a lot of it is very similar to the patients. Again, these were not paired dyads of caregivers and patients, so it's probably a totally separate group of people. But overall, the rates of decision regret were very, very low for our caregivers. So, so in a way that was reassuring that maybe we are having the right discussions before surgery and we are preparing people. But despite all of that, half of our caregivers are still experiencing high burden surrounding this, their loved one's diagnosis. Financial toxicity also was measured to be quite high. And then regret was related to worse quality of life. So this is not definitive by any means. This is meant to be a starting point for understanding the experience and exploring more. So in terms of future directions, you know, the collaboration with ACPMP has just been invaluable. And again, I cannot thank you enough for responding to the surveys and getting involved, because we really, really want to hear from all of you. In terms of funded research, these are some areas we're looking into in terms of interviews and how do we implement more support services for our patients and caregivers. There's a lot of opportunities for systemic change. And I know that at this point in history, you know, trying to secure funding can be a little challenging, especially in our academic centers and through the Cancer Center. But I think we just need to keep going and keep trying and advocating for why these kinds of services are absolutely essential for our patients and caregivers. So I will stop there and hand it over to Dr. Kopecky.
Thank you. That was amazing. So excited to be collaborating and teamed up. Let's see if I can share my screen. Can you see this? Let me try presenter mode. Okay, perfect. Is this looking okay, Melissa?
Yep, good to go.
I get it? Okay, awesome. And this is not the slide that I meant to start on. Let's see if I can go all the way back. Should have fixed that before I logged on. You guys got the preview. Okay. I'm Dr. Kopecky. I guess I'm Kimberly. And I'm an assistant professor at the University of Alabama in Birmingham. And I'm going to talk a little bit about the importance of expectation setting, particularly as it relates to both high-risk abdominal surgery for cancer and specifically patients with primary and secondary peritoneal surface malignancies, including appendix cancer. So there is often, as none of you will be surprised, especially those that have undergone or have had loved ones go through surgery, there is often a mismatch between what patients expect surgical recovery to be like compared to the actual experience. And we have data that suggests that patients experience disappointment, anxiety, stress, fear, anger, and resentment when their surgical experiences diverge from their expectations. So this is like a really phenomenal graphic that I absolutely love. And you can imagine that if you're expecting your experience to be something like the top line, going from A and doing something, maybe surgery, to achieve B, if that's your expectation, but the reality is more like the bottom two lines, either A still gets you to B, but the road is a little bit more rocky, or A actually takes you to a totally different destination than you were anticipating on top of having a rocky road, that this gap between what you were expecting and what the reality of your experience was is actually suffering. And suffering is fundamentally rooted in a mismatch between expectations and reality. This is something that I like to say, but also for my own credibility, I like to highlight that this was also quoted by William Shakespeare and the Buddha. So suffering is rooted in a mismatch between expectations and reality. As surgeons, it's impossible for us to control every kind of nuance of the patient's postoperative recovery. But if there's any chance I have of reducing patient suffering, it might be by better aligning patient expectations with the reality of surgical recovery. And that's what motivates my work. So when I started getting interested in this and when I made the transition from finishing 9 years of surgical training and heading into early facultyhood, I began reading the literature and I found 3 papers that basically captured this concept of why expectations matter, or at least noted that expectations do matter. So the first one was this publication by Abelson et al., and the paper is titled Sources of Distress Among Patients Undergoing not underdoing, rather undergoing surgery for colorectal cancer. And the authors found that there was a mismatch of expectations in the experience of recovery, and that dealing with distressing physical symptoms and complications after surgery contributed to distress. In addition to distress, worrying about recurrence once people had gotten through surgery. The second paper that I found was called The Patient's Perspective, a qualitative study of experience with decision-making, treatment, and recovery for resectable pancreatic cancer. So we're not quite yet in the world that's specific to CRS HIPEC, but we are talking about high-risk abdominal surgery for malignancy. The authors found that as reported by patients who were qualitatively interviewed, expectations differed from the actual experience of having surgery. And then the third paper is The Patient's Perspective on Supportive Care Needs Regarding Major Abdominal Surgery for Cancer. This was published by Chanel et al. In 2023. And the patients had reported that they wished for better expectation setting, that they had difficulty processing what to expect. So as I embarked on this journey to kind of explore this topic a little bit more closely, I did a systematic review, and we ultimately reviewed the medical literature and found 22 published papers that captured the experiences of over 3,600 patients. And the paper is titled Perioperative Expectations of Patients Undergoing Gastrointestinal Surgery for Cancer, a Systematic Review. It's currently under review, so I guess it's not quite published. This comprehensive review found that patients are uncertain about what to expect from surgery, as suggested by the prior publications, and that not knowing what to expect contributes to feelings of distress, anxiety, frustration, and isolation. We found that patients struggled to distinguish between normal postoperative symptoms and sign of potential complications after surgery. That patients express in the literature a desire for more information about anticipated and unanticipated surgical outcomes. That there are expectations regarding the length of surgical recovery that some patients thought would take weeks to recover from, and some patients anticipated would take years. So the breadth of expectations is not clearly set. And then most patients overestimated, the ability of surgery to achieve cure. Only one study out of the 22, and the only study that I was able to identify in the literature, evaluated the impact of an intervention where a surgeon or a surgical team intentionally did something to see if it helped patients set better expectations prior to surgery. So there has only been one study in the reported literature that I was able to find that evaluated the impact of an intervention on the preoperative expectation development amongst patients. These are some of the quotes from the literature that kind of motivated the early part of this work. Nobody mentioned anything about your life that it would never really be the same. When you don't know what to expect, your mind goes reeling in a million different directions, and it increases your anxiety. And then I had moments of fear, anger, panic, resentment that nobody told me how hard it would be. So I designed this project and got it funded internally, actually, through the UAB Center for Palliative and Supportive Care. And this original study is called Surgical Expectations. It was around high-risk abdominal surgery for cancer, and is not specific, like the second project that I'll discuss, to peritoneal surface or appendix cancer. This was my kind of original study straight out of fellowship. And the goal was to develop and test a tool to help surgeons elicit, address, and manage patient and caregiver expectations regarding high-risk surgery for cancer. So we completed 34 interviews with patients, 19 interviews with caregivers, and 10 interviews with surgeons. The patients were both pre-op, so I was asking questions about what they expected surgery and surgical recovery to involve. And then post-op, I asked patients how, now that they had recovered from surgery, how did their expectations align with or how did their experience rather align with their expectations from before surgery. I had a mix of male and female, a mix of diverse racial and ethnic backgrounds, and a mix of patients with prior personal surgical history versus HIPEC or not HIPEC, sorry, abdominal surgery for cancer being their first surgical experience. The caregivers were 8 pre-op caregivers, 11 post-op caregivers. I had a mix of male and female caregivers. I was actually quite impressed about the percentage of male caregivers in my sample, and then a mix of racial and ethnic diversity. And then we interviewed surgeons about how they elicit expectations from patients and how they set expectations for patients. Again, a mix of male and female, academic, private, and a diverse length of being in practice with diverse geographic location, although US based. So one of the things that we identified was that patients get information about surgery and recovery from various sources as anticipated. These are kind of all the inputs that go into how patients think about surgery and what will be involved. So you can see, basically from left to right, personal prior experience with surgery or experience having helped someone else through surgery, conversations with confidants, which include family and friends, faith, media, the things that doctors told them, so surgeons, oncologists, and other, and then proactive assimilation of information. And some patients rather, are very proactive about knowledge assimilation and learning about their diagnosis, and others are not. But there are a handful of sources for getting that information. One of the things that I found, and I guess I really should have expected this, but I didn't. I'm going to go back so you don't read the slide as I'm talking. I really thought that I was going to interview these patients and say, like, can you tell me a little bit about what you're expecting surgery to be like? And I thought I was going to get like this list of what people expected, and I would be able to hold it up and say, like, look, this is exactly what patients expect, and this is how it compares to what the reality of surgical recovery is. Instead, and I don't know why I didn't predict this, but instead what I found was that there was actually like a wide range or like a really big spectrum about how deeply people thought about what would be involved. And then there was also a big range about their own, what I call, or what I've decided to call, projected okayness. And if you have a better lingo for me, that'd be great, because I have to write this in a surgical academic manuscript, and so I'm trying to come up with better lingo. But so I found people, I don't know if you can see my little cursor, but that the top left stars, I encountered people who had thought a lot about it and had done a lot of research, but they were really worried that everything might not be okay. I interviewed people that had thought a lot about it and on projected okayness were really confident that everything was going to go perfectly. And then there was a group of people that hadn't really much thought about it, but somehow still knew that everything was going to be okay. So here's kind of like, I'm going to just give you some of my patient quotes. Hopefully I'll also check my time. I think I'm doing okay. So in terms of the depth of thought, I had some patients that said things like this. My expectation is that once he's in there, he's going to say it's good to go, that the tumor will be removed, that there's no issues with my artery or veins because I know that they are wrapped around, and that my lymph nodes come back all clear. And then I'm going to wake up and he's going to tell me that there were clear margins and there was no infections. And of course, that I can pretty much get up and eat as much as normal. This is a person that had like really thought a lot about exactly what this experience was going to be like recovering from surgery. Then we had other patients that we interviewed that told me, I'm kind of expecting to be in the hospital for a few days, I guess. So like the range was really striking. There was also a range, kind of as I described, of expected okayness, and definitely put in the Q&A if you have other ideas for how I can say this. But there's people at the top of this who really expected to be okay. I do believe that this is going to be a little bit different, but I think after a couple of days, I might be fine with just Tylenol. A middle of the road was kind of like, I'm hoping I'll be okay. So yeah, I don't actually know, to be honest, I don't know. And then people on the bottom range who vulnerably shared, I'm terrified, and I'm afraid that I'm not even going to live through this. The last one that I didn't really position on that first XY graph, but was about level of certainty. So some patients were like really certain that they knew exactly what it was going to be like, and some people were really uncertain about what it was going to be like. So this says, you know, I know, I'm like, what are you expecting? Well, I'm expecting I'm going to go back to exercising 4 days a week, driving, and whatever it was that I was doing before. And there was like no question in their mind that that's what this experience was going to be like. And then other people, you know, were on the other end of the spectrum and said things like, so when I wake up from this, I don't know how this is going to go. So changing gears a little bit, that was the data, part of some of the data that I got from this surgical expectations project, which was high-risk abdominal surgery for cancer. And then in the middle of that, I decided to write this grant that was graciously funded by ACPMP and this SSO, which is the Surgical Society Foundation, about specific to rather CRS and HIPEC. So this project is called Patient Voices. And the goal of the project is to speak with patients and get information from patients who have undergone CRS HIPEC. Oh, sorry, I'm not even there yet. This is just a fact. Are you ready? Patients who have undergone CRS HIPEC are known to experience fatigue, pain, anxiety, depression, insomnia, dietary changes, changes in bowel habits, fear of cancer recurrence, and regret. And that is what prompted me to do this Patient Voices project. Sorry. We know that when these outcomes are unanticipated, patients enter the postoperative period underprepared to manage the physical and psychosocial challenges of recovery. There are more than 30 publications about quality of life after HIPEC, and I've listed most of them in this graphic screen catch. And so the goal of this project was to develop materials to better prepare patients considering CRS HIPEC for the realities of postoperative recovery in order to reduce distress, anxiety, fear, and uncertainty. So part of the overarching goal is to take published information that we know about quality of life and the realities of postoperative recovery, and to gather information from patients about what they wish they would have known before undergoing surgery. So there's 3 aims to this project. The first was to assemble a patient and family advisory board. The second was to learn more about what CRS HIPEC patients wish they would have known about surgery preoperatively. And then aim 3 was to evaluate currently available patient informational materials so that I can basically prove that what patients wish they would have known is not currently being disclosed in the preoperative setting. I successfully, or we, I guess, successfully assembled a patient and family advisory board. We have 8 patients and 7 caregivers. All of these patients have appendiceal tumors, both Lamb-Hamman and appendiceal adenocarcinoma. The patients themselves were diagnosed between 2017 and 2024, and all have undergone 1 or more CRS HIPEC procedure. And then the 7 caregivers are a range of spouses, children, parents, and siblings, some of whom are working and some of whom are not working. So we assembled the patient family advisory board, and we've had 3 meetings over the last 4 months, and we're making progress. The second aim is to get information from patients and family about what they wish they would have known, either leading up to CRS HIPEC or after having undergone CRS HIPEC. So the survey is designed to be taken by patients considering CRS HIPEC, patients who have already undergone CRS HIPEC, family or caregiver of a patient considering HIPEC, family or caregiver of a patient who has already undergone HIPEC. So the survey was designed with the input of my patient family advisory board, some of whose names are on this call. I was spying on the attendee list. The survey, depending on who you are, if you're a pre-op patient, a post-op patient, a pre-op family member, or a post-op family member, the survey is variable in length with multiple choice options and text entry questions. And I was very worried about the length of the survey, but we beta tested it amongst many of our PFAB members, and they all told me that it didn't feel too long. We are currently working on survey distribution strategies, and just today in our PFAB meeting, we were talking about how to get the survey, which is linked also by this QR code, or you can email Amber Taylor if you're interested in taking my survey, about how to get the survey to the patients that aren't already connected with ACPMP. So if you have friends also with appendix cancer, you should definitely feel free to share this link. And if you do have trouble accessing the QR code, you can take a screenshot of my research coordinator's email address and we can send it to you. This is a project that's actively ongoing, so unfortunately I'm sharing, not unfortunately, excitingly, I'm sharing the background of how it was developed and why, and I would love if you'd be interested in taking it. Our end goal of this project is to incorporate existing research about patient and family experiences into nationally distributed materials to help all patients and families be better prepared for surgery and life after surgery. Please consider taking our survey. My little graphics didn't show through here. This was a Mac to PC problem, but this was a heart emoji like this. And we deeply value your voice and your experiences. If you have any questions for me about either of these two projects, you can reach out to my research coordinator, Amber Taylor, who is amazing and who will make sure that your email doesn't get lost in my email inbox, and she'll make sure that I answer any questions. So we are so thankful, both Dr. Greenbaum and I, for being able to present here. I'll stop my screen share. And I'm so excited.
Thank you guys so much, Dr. Greenbaum, Dr. Kopecky. Those were super informative presentations. And I'm going to hand it back over to you guys for Q&A. A reminder that they'll be going through some of the pre-submit questions from registration. And it looks like we've got a few questions coming in the Q&A box as well. So take it away.
Yeah, I do want to note that during Dr. Kopecky's presentation, you did have some suggestions: anticipated wellness, anticipated post-surgical well-being, and then acceptability instead of okayness, which I think are all great.
I'm gonna take a
This is all
picture of
interactive.
this chat with my phone right now. Thank you, everyone.
All right, we will get to some of you, and I do see the first question that was listed, and we will actually, I think I'll get to that incorporated into the first question. So Dr. Kopecky and I did review the pre-submitted questions. Again, thank you very much for doing that. We're gonna alternate our responses and broke down some of the topics. We did also group together some of the questions so that we could make it a little bit more streamlined. But yeah, please enter more in the Q&A, see if we can get to it. So the first question was about new research into goblet cell adenocarcinoma, which I also grouped together with a question about signet ring and mucin producing cells. Again, I want to mention again as we go forward, Dr. Kopecky and I are both doctors and HIPEC surgeons, but very important to know we are not giving medical advice. We will talk in generalities, and hopefully the information that we give will be helpful in your own specific case. But and then the question in the Q&A was about goblet cell, but also about mucin. So when we say mucinous or non-mucinous, really it has to do with what we see under the microscope. Sometimes it's also what we see in the operating room. So with that pseudomyxoma peritoni I showed as an example of mucin, tumors can either have mucin or not have mucin, especially when it comes to adenocarcinoma and goblet cell. So in general, we think about non-mucinous tumors being more solid tumors and behaving more like a colorectal adenocarcinoma would. And as a lot of you know, a lot of appendix research, treatment, and therefore, recommendations come from colon cancer, which we also know that's probably not correct, but because it's a rare cancer, it's hard to study. So a mucin producing cancer is possible in goblet cell or adenocarcinoma. In terms of new research, we don't have any new clinical trials dedicated specifically to goblet cell adenocarcinoma. But I will say that there was a great debate at our annual meeting this year, the Society of Surgical Oncology, and many of you might know the name Dave Bartlett and Lana Bielik, who actually practices in Europe now. But the two of them talked about the data behind treating high-grade adenocarcinoma of the appendix with HIPEC, and goblet cell and signet ring do fit under that category. And I will say as a conclusion, most of the research came from retrospective studies. It is looking at outcome. They are looking at survival, but again, it's very hard to study these in isolation in a clinical trial. But the conclusion overall was that after careful patient selection, as in, are you a good candidate medically for the surgery, considering your other medical problems, for example, and your particular cancer, it was determined, actually, it didn't end up being a debate at all. Both parties agreed that HIPEC is indicated for these high-grade histologies. So even if you are responding to FOLFOX, in general, that's a very good thing, that tumors are shrinking while you're on systemic chemotherapy. But surgery can still play a role, even if it's shrinking on chemo. Again, talk to your surgeon more about that, but that is a common thing to talk about. The next question was about development of new, less invasive treatments and what studies are being done to determine the cause of appendix cancer, which seems to be on the rise. And again, I encourage everyone to look at Dr. Holowati's study that just came out in July from Vanderbilt, which showed exactly that in the most recent generations, appendix cancer has increased 4 times. There is a lot of hypotheses being discussed in our field, and again, a lot of very smart people working on this. I personally have an interest in environmental exposures, and that was mentioned in her paper as a possibility. One example could be, and again, this has not been proven at all, but we noticed that the uptick in incidence started to happen in the 1940s. The 1940s is when the industrialization exploded in the United States and the production of microplastics. There's some research about microplastics and colon cancer. Again, we have no data showing right now that microplastics cause cancer, but that's one example of a potential environmental toxin that we are going to be looking into. There are many, many more. Dr. Kopecky.
Love it. I got the question about where to find the most recent PMP research. It is possible. I know probably a lot of you are aware of sorry, not PMP Pals. Oh my God. PubMed. PubMed is the research, probably the largest and most easily accessible research database that is searchable by keyword. You can set up, if you make an account through PubMed, to get keyword specific like weekly emails. So anything that has been published or is indexed in PubMed that has been published each week, you can set up for either daily, weekly, or monthly emails to get auto alerted for anything with certain specific keywords. If you Google how to set up keyword specific PubMed alerts in Google, or maybe even ask ChatGPT, I'm sure it would be able to walk you through it. There's ACPMP clinical trials, and then clinicaltrials.gov is like a national assembly or way to kind of like housekeep and track all the federally funded clinical trials in the country. That I haven't myself searched in a while, but is absolutely searchable if I'm remembering correctly.
Thanks. The next question was about what is the status of ACPMP developing a patient registry tracking the ACPMP population, including statistics on patients, types of treatment, recovery, and monitoring tools. I know that that's been posted on the ACPMP website for a while, and having talked to Deborah Shelton, it is still very much in process. I will say that it's kind of been thrown into a more national discussion, which is really what we're talking about as a national registry. Many of you also know the name Karan Turaga. He's now at Yale and has spearheaded a national effort in terms of updating our guidelines. And if you are going to look up PubMed, as Dr. Kopecky mentioned, you'll see that there's a brand new set of expert consensus guidelines for peritoneal surface that really just came out last month. He really spearheaded all of that. So part of his initiative to have a more national consortium has been to talk about a national registry. I will tell you right now, it has not totally finalized. It's very complex to figure out how to create a registry and protect patient information and privacy. But I also personally talked to Deborah and to ACPMP about this as we go forward in new therapies. For example, PIPAC, or pressurized aerosolized chemotherapy, is another hot topic. And we would love to be able to collate our data nationally. So we'll see about we will keep you updated, but it very much, there's a ton of passion and interest in getting that going.
I got the question about the latest or best surveillance methods post HIPEC surgery. I think that I standardly use, I think like many people, CT imaging post-operatively for surveillance. Other things, sometimes tumor markers can be helpful, especially if tumor markers were elevated before surgery. And then for some patients, at least my own patients, I have trended circulating tumor DNA, which is a newer blood test. We do know that peritoneal recurrences are a little bit less sensitive than things like recurrence within solid organs. So the sensitivity for circulating tumor DNA to be positive on something like a Signatera test, for example, is lower than for intrahepatic mets, but better than lung mets, for instance. And then what to expect in the years following CRS and HIPEC, I think is an absolutely excellent question that I am so excited got submitted, but is so patient specific because it really depends on the extent of the surgery. So I think it's hard to give a blanket statement. I will say that the literature that's been published about quality of life for patients that have undergone CRS HIPEC tend to indicate that people have bounced back to a level of livability within their own lives that is somewhat normal-ish, or they're feeling more like themselves between the 4 and 6 month mark. With some lasting effects that kind of linger, and that it's definitely dependent on what all was involved during surgery. And so it's patient specific, but I think it would be safe to say that most patients kind of bounce back to a new normal that's not exactly like the normal that they had before. And that what to expect is highly dependent on what was required or involved during surgery.
Okay. This question is about dealing with a lamin when repeat surgery may not be an option. And I also grouped together some other questions when it says CRS HIPEC is no longer an option due to scar tissue, otherwise known as adhesions by previous HIPEC. And then strategies to avoid a bowel obstruction. So the first two I thought really pertain to when we get into the unresectable disease category, where the tumors either physically cannot be removed. Sometimes the scar tissue or the adhesions create something that's known as a, quote, frozen abdomen, where it's so dense, it's almost like concrete. And so as a surgeon, we physically cannot get into the abdomen. I would say that's relatively uncommon, but it can happen after HIPEC and it can happen after multiple surgeries. So with unresectable disease, really at this point, we are focusing on symptom management, and that can take a lot of different forms. I did mention PIPAC, which I'm hoping and thinking going forward, you guys will have even more information on. It is still in clinical trials in the United States, but I do think that going forward, it's going to be offered at more and more centers. So that is, again, a pressurized, aerosolized intraperitoneal chemotherapy. Right now, City of Hope is a major center. I know Stony Brook is. And so I do have some patients when they want a second opinion they have actually gone to those centers. Again, it's not widely available in the United States yet, but that has shown some potential palliative benefit in terms of ascites reaccumulating, and in very small number of cases, less than 10%, that treatment may actually convert people from being unresectable to resectable. So I would say at this point, it's a very interesting and promising therapy that they are using pretty widely in Europe and in the Middle East. But it is still being developed in the United States. But in terms of symptom management, again, and again, I'm preaching to the choir, looking at Dr. Kopecky, but involving palliative care specialists, to me is an absolute no-brainer. There's so many methods, both medication-wise, with other interventions, even psychological interventions that can help with unresectable disease. And strategies to avoid a bowel obstruction. That is along with how to prevent a postoperative ileus, which is when the intestines don't wake up after surgery. That is $1 million question. And we don't have an answer, necessarily scientific answer for how to avoid a bowel obstruction. Please understand that if you get a bowel obstruction, it's nothing that you did. There's no, it is not, we can't predict when it's going to happen. It is usually because of scar tissue or because of a tumor in this circumstance. So, in terms of, there's some literature in terms of, even physical therapists doing some scar work. Usually that's scars on the outside. They can help break up scar tissue. But really for the organs, we do not have a good medication or a good therapy to break up those adhesions. All I would say is stay active, as much as you can. Go for walks. People their intestines feel better when you're walking and physically active, but that also will not prevent a blockage.
Yeah, love it. My question number 8 is, what issues should my husband or caregiver and I expect if and when I need HIPEC? I'll kick that to, it really depends on what the surgeon anticipates will be involved. Dr. Greenbaum talked a little bit about the PCI score. And so one of the things that I commonly tell my patients is like, I ask, have you read anything about HIPEC on the internet? Tell me a little bit about what you already know. And the trouble is that, the extent of disease as dictated or documented by the PCI score can be a 3 and you can get a HIPEC, or it can be a 37 and you can get a HIPEC. You can imagine that both of those are called CRS and HIPEC, but they are completely different surgeries. One of the things that I get on and on about the trainees that I work with, they'll say like, this patient is after surgery day 3 from a HIPEC. And I'm like, I have no clue what that means. A HIPEC could mean like from here to the moon and back number of things, because depending on the extent of disease, the PCI score, and a number of various other factors, that means that like I either like took out their appendix and that was it, or I like did this whole 16-hour surgery. And so that means that the extent of what's involved with surgical recovery is just really absolutely dictated by the extent of surgery. So that is a great question for your surgeon. Somebody wanted to make an amazing comment that asked us to let people know that there can be amazing outcomes after HIPEC surgery, including living a normal life for several years. And I would say that I think that this is true. I haven't been in practice for, several years, but I have patients that are thriving and doing well, and that is certainly on the list of possible outcomes. It's not like a terrible sentence to live life after surgery. And then another question about a HIPEC in September of 2024, and they're worried that the mucin is starting to collect again. What are the next options? I think this patient or person had indicated that they were heading to Seattle for a second opinion. I totally would always concur. If you have questions about options, a second opinion is absolutely worth pursuing. And then I think this is getting closer, but the other questions in this category are, I'd like to know if the path that I'm on is the only path available. Again, I think it's never wrong to seek a second opinion. Diagnosed with Lamin after routine appendectomy, the doctor said that everything was removed with the appendix. But there's still questions. This person says that the specialist doctor appeared to be annoyed because the patient was asking questions. Sounds like you're asking good questions, appropriate questions. I'm sorry that someone indicated annoyance. And the theme, I think, here is that it's always good to seek a second opinion, with the caveat that we know that that is stressful, financially taxing, takes a lot of time and effort. Yeah, you're doing everything right. I'll say that. Okay, Alissa, and then we're just like at the tail end of this, and we'll get to the live action questions in a hot minute.
The next question was, looks like from a caregiver, my husband is 7 months out from surgery and struggling immensely with symptoms. His team has not been very responsive. I'm struggling with where to go for help and guidance on how to navigate. So in terms of symptoms, and I do think 7 months out, that's the cohort of patients where, it wasn't just around the time of surgery. We're now dealing with kind of more long-term. What Dr. Kopecky and I will always say is to start with your doctor and make sure that you are relaying to them exactly what's going on. I'm sure that you have already, but it's interesting how often I find my patients kind of suffer in silence and they don't communicate to me or my team what they're going through. And so that is our job, is to walk through this experience with you, and we want to know everything. So what I would say is and I don't know what the symptoms are, but I am let's say they're GI symptoms, because I think somebody else also asked about that. Dietary suggestions, increased transit time, problems with appetite. So we always want to start with making sure everything mechanically and physiologically is okay with you. We want to make sure you don't have an infection. We want to make sure you don't have a blockage. So we probably will undergo an initial workup, again, if you haven't already, with some blood testing, maybe a CT scan. Sometimes some stool testing, something like C. difficile colitis is very common in hospitals, unfortunately, can cause diarrhea. So we need to make sure that the symptoms aren't something that's very, very treatable. If all of that has been looked at, I know that's where sometimes people get to the end of the road in terms of what Western medicine has to offer. We have a lot of medications like simethicone, which is Gas-X basically for gas. We have, Imodium if you have diarrhea. We have laxatives if you have constipation. Those are all very effective medications. My personal opinion, which I will break into now, is that I do think probably bacterial imbalances in the microbiome has a huge part to do with this. We are finding that after surgery, after antibiotics, obviously with the chemotherapy, there's a lot of inflammation in the gut. That's probably affecting things. We do not have a way to measure microbiome imbalances right now in HIPEC patients. I hope before I retire at some point we will and know how to treat that better. But I also know there's a lot of complementary therapies that are very soothing to the gut. Like one example is ginger or peppermint. There is a great app from Memorial Sloan Kettering called About Herbs, which if you are interested in complementary therapies, I find is a great resource. There's a version for patients and a version for providers. Some of these herbs can be very, very potent, so you don't want to overdose on ginger, but it will tell you what some of the side effects could be. And more importantly, if you're on chemotherapy, your doctor really needs to know even what supplements you're on. But there are a lot of options in terms of, intestinal soothing supplements. The other question was about typical time frame for recovery. Again, based on papers, a lot of them came out of Wake Forest, who has one of the larger databases in the United States about HIPEC patients. I usually quote around 12 weeks is when patients may be getting, turning that corner, we say, like with their pain, with their appetite. I definitely have patients that Dr. Kopecky was saying, maybe they had less removed or they had a shorter surgery. And I have patients that are just dying to get back to work. I think the record that I had was 10 days, which I do not recommend. You should take longer than 10 days off. but he just loved his work and he felt like he could go back and do a little bit of desk work. Whereas I have other patients, and again, this caregiver that wrote in, her husband's still having symptoms at 7 months. So again, frustrating answers, everyone is different, but in general, I quote about 12 weeks, give it that period of time to at least get back to, for example, work.
This person was curious about the kinds of support available for families of patients with appendix cancer and HIPEC when they return home. I think there's a handful of different types of support. I think that not feeling alone, this is really hard. I refer almost everyone to ACPNP and PNP PALS, which is ACPNP is more like research advocacy information, and PNP PALS is patient and caregiver support. So if you don't know about PNP PALS, if you Google the word PNP PALS and the word appendix, because I haven't made my nationally distributed informational materials for patients and caregivers, right now what I do is I take a blank piece of paper, fold it in half, and write number 1, ACPNP plus the word appendix, Google it, and number 2, PNP PALS plus the word appendix, Google it. But in terms of like physical, tangible support, I think sometimes things like home-based physical therapy, home nursing is an option depending on how soon after surgery you are and what you're dealing with after surgery. That can be set up by your surgical or your medical team. Kinds of support, dietary recommendations. I think that's also a little bit patient specific. For patients, I have patients that struggle sometimes, with eating and nutritional options. I refer to my outpatient nutritionists that do telehealth check-ins every 2 to 3 weeks until people get back on their feet. So if that would be helpful. We also have a psychosocial component. So our cancer center offers psychological support for patients, though not yet. Well, caregivers too. Maybe that's new. For patients with any type of cancer. And so I always have a very free hand making suggestions for that type of support if and when I feel like it would be beneficial. We are down to the last few questions.
And I'm going to throw in, just because you did such a good overview of that, there was a note in the live chat about what kind of in-home care would a patient need when family lives far away. So you just mentioned a bunch. I would also say it does, again, depend on your situation. Are you of advanced age and maybe had, some mobility issues to begin with, or are you young? I would think about the basics of, getting access to food and, before you go home, we do, and not to a rehabilitation facility, for example, we do want people being up and walking, for example. You're not going to be going home bedbound from the hospital, but it is good to have support at home, and it, including what Dr. Kopecky mentioned. So I think we can
I think we're
close
good.
out here. I think I'll just mention the last question, which was about genetic causes. And it was someone who said, me and my sister came down with appendix cancer within 3 weeks of each other. Again, pretty striking considering it is a rare cancer. And then would this possibly point to being genetic? Yeah, so I think it's pretty undeniable that there has to be a genetic driver, especially in a case like that. There is more information coming about genetic drivers of appendix cancer. There are some signs that maybe there are genetic drivers more in genetic cancer than even some other GI cancers. But again, very smart people working on identifying what those genes are exactly. If you do have a history of cancer in your family and you're diagnosed with appendix cancer, if your doctor, surgeon doesn't bring it up already, I would absolutely ask about genetic testing, or at least genetic counseling is the first step to that, and see if you would be eligible for genetic testing. Okay, we can go to the questions. So we talked about the first one. Kim, I looked at this longer paragraph. I think I can summarize it, but do you want to answer your thoughts on PET CT for surveillance of appendix cancer?
Oh yeah, that's great. So I usually tell patients, tell me if you say something different. A regular CT is a little bit more high definition. So a regular CT is like a 4K picture of each slice as we look through the abdomen. So it gives a little bit more crispness to the image. A PET CT is definitely not as crisp, but gives a different type of information, which is hypermetabolic activity of a tracer that is given before the PET scan. And so I kind of sometimes I'll draw out, the slices on a regular CT are not as tall. There's like more number of cuts, so the definition is higher on a regular CT scan. And sometimes I prefer that because you can see smaller things. A PET scan is really designed to pick up avidity. For surveillance, I personally prefer a regular CT scan, not a PET CT scan. A PET CT scan is usually used at the initial stages of diagnosis when you're trying to get a sense for the total extent of disease. And then I think, a regular CT offers like a higher definition picture and is usually what I and probably most people use for surveillance.
I agree, for all the reasons that you mentioned. And then also, if it is a mucinous tumor, mucin does not light up on PET scan. But I agree, it's not usually part of our surveillance for the reasons that Dr. Kopecky mentioned. I will summarize Lisa's comment. Thank you for writing that. She said her HIPEC surgery is in a few weeks, and that she trusts her surgeon. She's gotten a lot of information, struggling to find information though. So when I look through this, it sounds like you had an appendectomy, you were found to have a lamin, but it's how I'm interpreting this question is it's getting down to, is lamin cancer? Is acellular mucin in the peritoneal cavity considered cancer? And the reason why it's hard to answer is it is somewhat of an existential question. I will do my best to explain how I think about it. So cancer, by definition, has the ability to spread to other parts of the body. The thing about lamins, which is confusing, is that it does not go through the bloodstream and go through the lymph nodes and go to the liver, but it can spread to the peritoneal cavity because it ruptured. So in that way, you can have a non-invasive cancer in your appendix that ruptured and is now considered stage 4 because it involves the peritoneal cavity. It's a hard thing to conceive. So you're not alone. And I will tell you, as Dr. Kopecky said, training our residents and students to understand these disease processes, it takes time. I would say that there are some great review papers on PubMed. I think that the new guidelines that just came out are pretty extensive. They're almost 20-25 pages each. But if you look back to the Chicago consensus guidelines, those are much shorter and they're still good. So you can maybe look at the one for lamin.
I'll also say,
Dr. Kopecky, you had a question about your
yeah,
getting third-party payer authorization to pay for the blood test. I'm assuming that's the ctDNA.
ctDNA probably. Yeah, I'll totally answer that. Also, just to add my like 2 cents onto
Yes.
Lisa's question. Like if your PCI is 6, I'm just throwing out a number. And you have lamin, and your PCI is 6, and you have adenocarcinoma, the surgery will be the exact same. There's no difference in the surgery itself. So the symptoms are likely, if you have symptoms, are likely to be similar for like an equivalent extent of disease. The surgery will be the same. The surgery doesn't change because of the underlying diagnosis. It's the likelihood of recurrence that changes after surgery and the aggressiveness, like Dr. Greenbaum is saying, the lamin doesn't have the ability to leave the abdominal cavity, but adenocarcinoma does, for instance. But if you're asking specifically about what surgical recovery will be like, will it be different than appendiceal adenocarcinoma because it's a lamin? No. Your surgical and postoperative experience will be dictated by the PCI, and the experience is equivalent no matter the underlying etiology, though the recurrence risks and stuff are different. Okay. My hospital system, and I cannot speak for anything else that happens across this country, but Usually the company that does the ctDNA test will pay for it. If insurance refuses, denies, or patient doesn't have insurance, the company itself will pay for it. I have to believe that they're making so much money for the people that do pay that they're using it to fund patients whose insurance doesn't agree to pay. But is it similar in your hospital, Dr. Greenbaum? Like the
It
company
is.
will pay for the test.
Yeah, they'll absolutely, which I was pretty shocked by because there's not a lot in medicine that's free or covered outside of insurance. But again, our population here, we have a lot of Medicare, Medicaid patients, and a lot of people cannot afford it. I think that it's up to, I want to say $200 or something. Like they might have to pay a little bit, but the test itself is probably out of pocket thousands of dollars. And yes, the
It's
company does pay
thousands.
for it.
Yeah.
Yeah.
But the company will cover it.
We have two more
I'll send you.
questions. I think we have 5 minutes. I think we can squeeze it in here. Is that okay, Alyssa?
Yep, I was just going to say you guys do have time for a couple more questions.
Fantastic. Maybe I can answer the Bromac and
Love it.
Kim, if you want to answer because I saw probably the most recent data in the US was presented again this year at the Society of Surgical Oncology. It was, I believe it was out of Moffitt. And again, by clinical trial, we mean it is in phase 1, which is testing feasibility and safety. So this really this came out of Australia, and that still was in the experimental phase. So the status is that they did use it in a clinical trial in patients. I would say there's still a lot of promise about it. It's definitely not without risk. And that is the reality of, any kind of invasive intervention we're going to do. I can't quote all of the data off the top of my head, but I know, for example, one patient had a fistula or perforation. You are injecting an enzyme basically into the peritoneal cavity, and it is an invasive procedure. It's not open surgery, but it still is introducing a needle and injecting. So it is coming along. I was really excited to see that there's a trial that exists in the United States. And so I also am keeping my eye out for when we're going to prove safety and in which patients exactly we should be using that in.
I'll take the last one, which is info or data about the success of cytoreductive surgery with or without HIPEC. I would say that probably the vast majority of HIPEC surgeons believe, and you tell me if you think differently, Dr. Greenbaum, that the key component of surgery is the cytoreduction. I will not take anyone to the operating room who I don't believe I can achieve a CC0, which is a complete resection, or a CC1 for Lamb patients. So outcomes are vastly improved and dependent on the extent and success, I guess, of the surgical resection. And that, in my mind, is certainly the driver for overall survival. I don't know what your thoughts are.
Yeah, so to me, I totally agree. But to me, this is where what we know about appendix cancer, which is honestly mostly retrospective data looking back, and then colon cancer, which is still, the addition of HIPEC to cytoreductive surgery is very controversial in our field still. In colon cancer, we have a trial showing that it might not help, and we have a trial showing that it does. And now we have a new trial that we're all waiting for the results on to answer that exact question. For appendix cancer, I think, all of the experts agree, I would say internationally at this point, that especially with that mucin, and because there are no good alternatives to treatment, we know that systemic chemotherapy does not work very well. Systemic as in it goes through your bloodstream through a port, and that the rationale in the lab in patients is that the HIPEC does kill specifically, these mucinous cells. So if I plan to take an appendix cancer patient to the operating room, I do offer them HIPEC.
Yeah.
I think we'll stop there.
Yeah, I tossed into the resources this there are some questions early in the discussion about goblet cell versus something, and I have this outline on my desktop that I converted into a PDF while Dr. Greenbaum was talking in the beginning and dropped it in the resources tab, just in case that would warm anyone's heart.
Great.
Awesome. And I can also add that to the little thank you email that goes out after this so they can have access to that as well. All right, so it's almost 8:30. I want to thank you both, Dr. Kopecky, Dr. Greenbaum, for being here today. I thought this was super informative. And thank you to everyone here today who's attended and has submitted your really thoughtful questions. Yeah. Thank you guys.
Thanks
Thank you for
sticking
having
around.
us.
Definitely. I hope everyone has a great night. All
Bye.
right. Bye, everyone.